Hello and welcome to the Doc Podcast. I'm your host, Dr. Mike DeLuke, and it's my mission to help you lead a happier, healthier, and more prosperous life, both personally and professionally. Hello and welcome to the Doc Podcast. Before we welcome today's guest, I just want to take a moment to express my sincere thanks and gratitude for your support of the show. When I launched the Doc Podcast back in June of 2023, I thought I'd have enough content for one, maybe two episodes each month. But shortly thereafter, the platform began to grow very quickly, and I'm now thrilled to be able to bring you weekly episodes with amazing and talented guests on a wide variety of topics. I also want to thank the many listeners who have taken the time to reach out to me and let me know how much they've enjoyed the content and the show. And they've let me know, too, that it's really helped them personally, financially, clinically, and professionally. I've even had parents of patients who listen to the show reach out to me and let me know that the content has opened their eyes regarding what's possible for the orthodontic treatment of their children. I want you all to know that your support and encouragement means the world to me. In addition, I do want to thank those of you who have taken the time to subscribe to our YouTube channel and sharing the show with your friends and loved ones, as well as giving us a 5-star review on Apple Podcasts. Your support is so important, and I really, truly do appreciate it. It also allows me to continue to bring you interesting and exciting content each and every week. I also want to assure you that as the show continues to grow, it will remain my mission to help improve the quality of your life, both personally and professionally, using this platform. Lastly, if you have any topics that you would like to hear discussed or possibly guests you would like to see appear on the show, please feel free to email me at drmike@theorthocoach.com. I'll put a link to that email address in the show notes for today's show as well. So thank you all so much again. And now on to today's episode. I have the absolute pleasure of being joined by a true superstar in the world of orthodontics, Dr. Derek Mahony. Derek received his dental degree at the University of Sydney and completed his master's degree in orthodontics at the University of London. He has 3 postgraduate qualifications in dental sleep medicine from the University of Western Australia, the City of London Dental School, and the Australian Sleep Association. He's been a leader in the education of dental professionals in the early diagnosis and treatment of sleep-disordered breathing problems in children. Derek also has a wealth of clinical experience with 36 years in practice, and he utilizes a treatment approach that focuses on the airway rather than simply just straightening the teeth, which I absolutely love and agree with. Derek and I also share a passion for the value of early interceptive orthodontic treatment and what it can do to assist in the growth and development of young faces, especially as it pertains to airway. We're going to discuss this and much, much more during today's episode. So with that, it is my absolute pleasure to welcome Dr. Derek Mahony to the show. Welcome, Derek.
Thank you. And thanks for the opportunity. I've been following your podcast for a while, and it's like everyone you interview is so much on the right page, which is refreshing for me, because in the land down under, if you want to call it that, we are so backward in this early interceptive treatment of airway. Mm-hmm. And it's embarrassing that our regulatory bodies, our dental association, always bring out the same old, no real benefit in early treatment. What's expansion all about? Mm-hmm. What's a dentist got to do with a medical problem? Mm-hmm. And I think Shireen, my colleague in Perth, yes, recently sent you a link to our latest, free lecture for every dentist in Australia and New Zealand on
yes,
why you shouldn't confuse malocclusion with airway. Yes. I think myself, what? Oh my God, what for such an advanced country, which Australia is, we are so far behind the 8 ball. I mean, as you know, I travel a lot, so I know I've got my pulse on the world, and I don't know how anyone can say that an orthodontist or dentofacial orthopedist, is not the perfect person to check the anatomy of the face. You know,
Right.
we all know anatomy affects breathing. Come on, like you speak to an ear, nose, and throat doctor who's going to rip out T's and A's and help breathing. That's in the literature.
Right.
So we know anatomy affects things. How could the maxillary size, position, mandibular size, position not affect breathing? I mean, it
Agreed.
just, yeah.
I know. I know.
Yeah.
It's when I speak with people such as yourself, Shireen, there's just, we all have this sort of fire in us that's just, we just can't even comprehend why the resistance. And as we get into things and talk about some of the science, I want to revisit that and come back to that and talk about that and how we can maybe change that, how people such as yourself, how we can get the message out, continue to try to change that. But for you, how did you become aware of it? I mean, was it in your training? Was it just in your practice? How did you see things differently than the traditional approach, which is, as you said, to oppose the concept that we can impact the growth and development of the face and therein have an impact on airway and breathing?
I guess just the right place at the right time. I did a 3-year residency in London.
Okay.
Great course. We had some fantastic instructors. I know, you had Charlie Burston and
Yep.
Ravi Nanda and
Yep.
all these greats in biomechanics. And so I graduated knowing a lot about moving teeth.
Yep.
Okay.
Right. Sure.
But I had no clue on interceptive treatment. We didn't
Mhm.
see kids in mixed dentition. It was the National Health Service. People, by the time they were, name came up for free orthodontic care, they were already 14 or
Yeah.
15,
Interesting.
etc.
Okay. Yep. Mhm.
But luckily for me, I had the opportunity to do some research as part of that time, and I
Okay.
spent some time in Sweden with a famous orthodontist, Sten Linda Aronson.
Mhm.
And Sten had been working for years on studies looking at facial development and its link on breathing, which was back then, leading edge new stuff. And
Mhm.
he paired children, and his control and his sample group were very well put together.
Mhm.
And he just looked at something simple, which is if you had large adenoids
Mhm.
versus not, how would your face develop? And secondly, if we remove these adenoids and we followed the child's facial development without any orthodontic intervention, years later, would there be a difference? And
Mhm.
that's become a landmark paper. I mean, the guy was a true researcher. I think he measured like 177 landmarks on
Wow.
this
Oh
study.
my
And,
goodness.
and his conclusion was mouth breathing definitely affects facial form. You get narrow upper
Mhm.
jaws, longer faces, more dental crowding. And then
Mhm.
when he looked at the sample group who had adenectomy and were taught how to breathe through their nose, huge change
Yes.
compared to the control. So that was what really got me excited about this. And of course, I came back to Australia to set up practice. I didn't want to leave London. I mean, London to me was the center of the universe, right? I
Mhm.
mean, as you have you been to Australia at all?
I have not. No.
Well, I'd love to come get you down and do a lecture or so, but
Oh,
you'll
that'd be
realize
great.
it's a hell of a long way, right? So when you when you're living in London, you can go to Greece for the weekend, etc. In Australia, everything's like a 2-day trip
Yep.
away. So anyway, I recently married. Young kid on the way, and my wife said, "Oh no, we got to get out of here. We got parental support." So I came back to Australia reluctantly, and of course, I came back with this passion, wanting to do early treatment, right?
Hmm.
Because I saw what was happening in Sweden, and, and
Sure.
and the great results are getting in what they call phase one. Now, phase one wasn't even heard about in Australia; like no
Hmm.
one had a clue. So I took a bit of a risk.
And about when is this?
Normally,
About what year would you
this
say?
should have been 1990, I think.
Okay.
Yeah.
Okay.
Uh,
Yeah.
and, uh, everyone I spoke to said, this is what everyone did in Australia, right? You particularly in Sydney, which is where I'm from. You literally did your residency here. You joined one of the big orthodontic practices here, and you slowly bought your way in. And that's how it stayed for years and
Mm.
years, right? And I looked at some practice opportunities and I saw what they were doing. A lot of the practices were still doing beg orthodontics, which was,
Hmm.
classic four on the floor, retraction, headgear.
Hmm.
And when I realized what I could do, I said I took a massive risk, and I just put up my shingle and I started knocking on people's doors and saying, "Hey, I'm new in town. I'm doing this new approach where I'm focusing on developing the arch to minimize extractions." And guess what? The practice boomed
Hmm.
because parents wanted this. Referring dentists were looking for someone to do this, and to me, it just made common sense. So that started my whole journey on this. So thank God for Linda Aronson and my original research, which helped me a lot eventually when I started doing my formal PhD on malocclusion and airway, and does breathing, particularly mouth breathing, influence the way your face develops and potentially causes more crowding, because not because you have too many teeth or you have macrodontia, but because common sense, you have an underdeveloped arch.
Hmm. Yeah, no,
Yeah.
completely. And that it's so funny. We've spoken before, but I didn't realize that our stories were that similar, and in an interesting way. I didn't have quite the time preceding me, obviously in another country, but after I came out of my program, I had this sense that just pulling a bunch of teeth on these narrow, small little arches at 6, 7 years old, I just struggled that I wasn't treating the etiology. It just was something in me that just didn't feel right. So I started being more aggressive in trying to make room on these patients. And I literally went door to door to over 100 dental offices because I hung a shingle and had literally within a week of finishing my residency at UConn, I opened my practice and went door to door and let people know I was there. And one of the things that grew my practice the most quickly, again, I wasn't using it as like a sales pitch. I literally was just approaching this differently, is people would send me patients and they loved the fact that I wasn't instantly sending these kids for pulling teeth, and I was trying to actually solve the etiology. So it's so ironic that as we have spoken, we realize how similar we are now, many years later. But both of us had a very similar path that we followed, where we just saw this thing that was different, and it grew our practices kind of unintentionally, really, just by the nature of the fact that I think that brings up another really relevant point. Is it seems like a lot of people absent orthodontists, this is very much common sense for, right? I
Yeah.
feel like it's, the lay population, our general dental and pediatric dental colleagues, like the medical community, most of them, like, they're like, why is this not, is I heard, if I heard thousands of times people ask me, why isn't every orthodontist doing this? So talk to me a little bit about that. Why do you think people such as yourself, myself, that are orthodontists, why are we the outliers still? And it is changing a little bit, for sure, but it has a ways to go. Why is that?
Maybe residency training, where I
Mm,
don't know one residency program. I mean, hey, I'll correct that. I think thank God for people like Audrey Yoon,
hmm. Oh yeah.
who now at University Specific makes this part of the curriculum. But I
Yep.
don't think I know of any other orthodontic residency program that even mentions airway
Yes, you're right.
or the info, which is crazy, right?
Yeah.
So I think many of orthodontists, and I was interviewing for a new associate. And to me, I don't care where they graduated or how great their marks are. I just always present a mixed dentition case with a really narrow airway,
Mm,
classic adenoidal face. And I kind of ask the newly graduated orthodontist, like, what would you do here? Right?
mm,
And you'd be amazed the responses I get.
mm.
But the average response is like watchful waiting. You know what I
Yeah,
mean?
yeah.
Which to me is like, honestly, it's criminal. It's what I
Yeah.
call supervised neglect.
Yes,
Like,
love that term.
let's
Yep.
just monitor this kid while their academic performance keeps dropping
Yep.
down, where
Yep.
their cognitive development, and let's just wait until we're in our comfort zone where we have four premolars. Otherwise, we don't know what to extract. You
Right.
know what I mean?
Right. Right.
Uh,
Right.
so,
Yeah.
uh, so getting back to your question, it's the way you're indoctrinated. I didn't get
Yeah.
one lecture on this. I'm sure you did it in
No.
UConn.
Nope.
And I mean, it's funny. I know Ravi Nanda really well. He's a
Mhm.
super nice
Yeah.
guy.
Ravi's
He's
great.
the academic's academic. But you
Yes.
go near him and start talking about airway and early treatment. My God, he explodes,
Oh
right?
yeah, no, trust me. Yeah, I love Robbie, but when it comes to my
Yeah.
philosophy on my approach to treatment, we don't. I always say being trained by guys like Nanda and Burstone taught me so much about biomechanics
Yeah.
and the principles of
Yeah.
orthodontics that really made me the orthodontist I was. That being said, when it comes to the teeth moving side, but that being
Yeah.
said, we didn't get anything in the early phase one treatment side. And anytime I've had interaction with him in that, he has certainly not been super favorable on my approach to it. And I think a lot of
Yeah.
that, at least in the US, I was talking to Rebecca Baca about this, and I was saying to her, I think a big part of it is we don't see patients that young in residencies in the US. We just don't. And there's reasons for that. Some of it's financial, because if these patients are on state funding, the state doesn't count. We use the Saltzman index, and the state doesn't count the primary teeth. So we do a lot of screening of like 7, 8, 9-year-old kids. And we just, like, exactly like you said, just find ways to wait and watch, and then ultimately go extract some teeth when the insurance will cover their treatment. So you have a system where you were talking about, where there's this delay getting into the system, right? And by the time they get in, they're a teenager. We have kind of the same thing in that they can come into the system for a screening, but there's really nothing that can be done to cover their care. And because a lot of residencies, I'd say most residencies, treat a very high percentage of their patients who are on our Medicaid system or state funding, they are going to automatically, by default, not be a candidate. And I think when you come out of a program, and all of our programs are, any of our education is indoctrinating in some way, shape, and form, right? We come out with the knowledge and the ideas that we were taught year after year, day after day in these programs. Well, if you never treated a kid 6, 7, 8 years old, and if you only did phase one when it was like a bilateral or maybe unilateral crossbite, even if you got to even do that and you put an expander in, never talked about airway, never looked at growth and development of the face outside of it and the impact of mouth breathing or snoring, which I want to get into next. I guess it makes sense how we got here. I mean, when you think of it that way. Do you have questions about a clinical case, or maybe a challenging practice management issue? Or maybe you're a new doc who's starting a practice and doesn't know where to turn for advice. Doc's private one-on-one coaching platform is here to help you succeed in all these areas and more. Just go to theorthocoach.com and select coaching from the menu to enroll. And now back to today's podcast.
Yeah, look, absolutely. And I'm sure these young residents that I was interviewing recently have probably never had a mixed dentition kid in the training environment, because exactly as you've said, the system is such that there's such a long wait, and, et cetera, et cetera. But I just, I always love your saying on one of the podcasts, but you use the word quarterback, and in Australia, no one would have a clue what a quarterback is, but I kind of figured it out. He's the person who's controlling the plays in your AFL, right?
Yep. NFL. Yep.
So maybe if you want to become Aussie, you would say, well, the halfback, right? Or the but when people say the quarterback should be the pediatrician, let me tell you about pediatricians I know in Australia. They are so busy doing the stuff that kids get, which is which I might, if we have time, talk about related to what we do. Like, the most common reason someone goes to a pediatrician in Australia for the first time is recurrent otitis media, right? And I can tell you, that's so linked with narrow palates. The eustachian tube and tensor levator palatini, and your ability to swallow correctly to clear that eustachian tube. But anyway, any of these pediatricians, they never ask questions like, "How's your child sleeping? Does he snore at night?" They just don't do that. So how could you say that can be the quarterback for a child's health? I mean, I love reading the research of David Gozal, right? I mean, he's the guy to link, forget about teeth, forget about our profession, but what about a kid's cognitive development? Oh my God. And he's mapped it all out. So every time a kid is misdiagnosed or diagnosed and not treated with sleep disordered breathing, it is affecting a lot more than their teeth and jaws. And I know that that's what this podcast is a lot about, but the bigger picture is getting these kids health. And I think we as a profession should also almost feel like oral physicians rather than tooth straighteners. Like phase one, if you want to call it that in Australia, is still line up 4 teeth just to keep the parent happy. That's what a lot of orthodontists still do, paying no attention to
Yep.
arch development or airway. It's terrible.
Yeah. Yeah.
But
That's exactly my experience with the pediatricians in the U.S. And before I want to come back to kind of talking to you about your process a little bit later on referring and coordinating with your medical colleagues to hear how you approach it. But when I first started seeing this and realized I was seeing a problem in airway, when I first had my cone beam back in 2014, I would call the pediatrician and ask them, hey, I'm seeing this. First of all, I was lucky if they called me back. Like you said, they're so busy, they're so buried. They're like, what's the orthodontist calling me for this about? And then when they did call back, it was like they're looking through the notes and like, I don't have any notes on this. I don't see anything. They haven't had strep 5 times, so I don't really think there's any need for it. And it was only because of my involvement on the cleft craniofacial team that I started picking the brains of the ENTs and saying, hey, look, I'm seeing these things on these cone beams. I'm seeing these symptoms in clinically expressed in these kids. Can I just send it patients right to you? And they were like, absolutely, don't go through the pediatrician. They're not, they're just going to kind of be a gatekeeper to this. And that's really what opened this up for me, because then I just started working with the ENTs and picking their brains. And I think a big part of this, and this gets into, problem I have with the AAO white paper is, again, they make the pediatrician the quarterback. They essentially say, they do that. There's some good things, good points they make about it and investigating it, but they ultimately said that we need to refer the patient back to the pediatrician when we notice anything, and they dictate the care. Well, I don't know about pediatricians in Australia, but pediatricians in America do not have any idea, by and large. Obviously, there's outliers, but generally speaking, they're not exactly well versed, nor should they be. That's our job as the orthodontist, in the craniofacial growth and development and the ability to help grow a patient young. And I think a big problem in this, and I want to hear your thoughts, is the misrepresentation of what we're really looking for and looking at. And I feel like we spend so much time, and if you look through literature, people who are very opposed to the way you and I approach these things, they all talk about obstructive sleep apnea, OSA, right? We know the scale for OSA for children really has minimal validity. It was not done based on any research or studies. It was an extrapolation of the adult data. We know the sympathetic nervous systems of younger kids are more active, and so they don't tend to have these long periods of absence of air and oxygenation for greater than 10 seconds. So they may not scale super high with polysomnography. Yet they still have what you and I know as sleep disordered breathing. And I think the ADA did a much better job. They called it sleep-related breathing disorders, same concept, but it's essentially taking it, including snoring. So the American Academy of Otolaryngology, head and neck surgery, they estimate, so they defined sleep disordered breathing as a general term for breathing difficulties occurring during sleep in children, ranging from frequent snoring to obstructive sleep apnea. And I think when you just focus on that latter, the obstructive sleep apnea, that end stage disease, you're missing so many of these kids. And the studies of David Gozal, like you quoted, and so many others, they've shown that just mouth breathing alone is sufficient, and light snoring of any amount. The one study by Isaiah in 2021 in Nature Communications looked at the MRIs of over 10,000 children and found that children who snored or even gasped during sleep had smaller volumes of gray matter in their frontal lobes. 10,000 children. So the data are there to substantiate this. But I think, and this is what I want to hear what you think about it, is I think we get really caught up in this whole, and it's almost a nomenclature problem. We're so stuck on defining it as OSA, and orthodontists can't diagnose OSA, and you can't treat OSA without the help of a physician. Number one, we're not talking about adults, we're talking about kids. And number two, I think that's really misguided. So what do you say about that?
Look, I spent a lot of time with Christian Gumino when I was getting really into the sleep, and I thank Stanley Liu and Audrey Yoon for making those intros for me. And Christian Gumino, who's like the father or the godfather of sleep, he regrets making up an indice, because he said everyone is treating to the numbers rather than the symptoms. And you're quite right. I mean, there's been lots of research on OSA, not a lot of research on sleep disordered breathing. The scale is all based on OSA for adults, and then they just extrapolate it to children. Now, how many times have you sent someone for a sleep study where all they measure is the apnea index, AHI, and the kid comes back normal. But
Yeah.
the parent knows the kid is not normal.
Right.
The kid is not sleeping well at night. The kid is wetting the bed. The kid is snoring like a Trojan. The
Behavioral
parents note the
problems.
kid.
Yeah.
Yeah, right. And yet on that little scale, the kid is normal. Well, I think we've got to start looking at a lot more than just those numbers. And that's where a lot of the academics actually, I think, get it wrong, because they're not clinicians. They're not in the coalface like you and I are. Do you understand that?
Yep.
They don't get the parents knock on their door and say, what are you talking about? That there's nothing wrong with my kid. I can tell you blah, 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 blah. And then, the most rewarding thing I get in my practice is a letter from a parent who said, Derek, you may not remember me, but you treated Johnny 20 years ago. You're the only one who picked up that he had a sleep problem. He changed, it would change his academic performance. I just wrote you this letter to let you know that Johnny finally got into medical school.
There's nothing like it.
And yet when I first saw Johnny, he was probably in grade 4, bottom of his class, not doing well at school, and was told, he's just one of those kids. So you'll never get reward of our profession as good as that by just straightening the teeth into what do you call it, Andrew's 6 keys or whatever we were taught, right? That's what makes it. That's why I get out of bed every morning, and I'm just like you. I'm passionate about this because you're just helping kids being the best they can be. And how many times have you heard that statement from a mum? Thank you for giving me back my child.
Yes.
Or it's life-changing stuff. And this is not the 1 in 100 kid. This is like, in my practice, at least, the norm. Australia has the highest usage per capita of Ritalin. We have
really?
the highest.
Higher than
we have
America.
the highest teenage suicide rate than any other country in the world. And more medical researchers are looking at the sleep as that major thing. Australia is very famous for sleep research, right? Like, we have the Epworth scale that was developed here. Colin Sullivan developed the CPAP machine. So we're an industry leader on that. But, I think we are falling behind in what is the correct treatment. And we'll talk about that hopefully later. But, when I started doing the sleep side of my training, it was all about, well, if they have OSA, just measure that and then whack them on a CPAP. And that's it. That's standard of care. And yet I'm seeing a common thing in all these kids who are diagnosed with OSA, and that is craniofacially, they are retrognathic. Everything's back. My biggest referrers are not dentists. It's sleep physicians. It's pediatric, otorhinolaryngologists, so what we call ear, nose, and throat doctors. It's parents who had treatment done with the thing, and it's the medical model. Whereas in the past, it was all about, all right, well, you go to your dentist, and your dentist says, oh no, I think your kid's too young to go to the orthodontist because they haven't lost all their baby teeth yet. And that's what most dentists think, right? Whereas the medical model, once they realize there's a link, they are sending you a lot of the kids at the appropriate age. And you and I know the appropriate age is going to be like, depending on who you read, like Kevin Boyd, fantastic researcher. Yeah, I mean, he's treating as early as 4 and 5, right? And I'm just starting to get into that and seeing some amazing sort of outcome. But my comfort zone is 7 to 9, and I've been achieving so much in 7 to 9. Yet my comfort zone out of residency was, high school, or like what we call grade 7 and beyond, which is like 12, 13, 14-year-old kid, where I now know that we've got to miss the boat in a lot of this stuff, and particularly if they had undiagnosed sleep disorders and we didn't do anything about it. It's kind of it's terrible stuff.
It's so well said, and I echo everything you said 110%, and thank you for laying it out like that. I love your passion for it. I share that fire. I also, that is what motivated me to go do this and be so active in this arena and try to be a loud voice in this arena, was those parents, those patients. And I say often, I said this in an episode preceding us with Rebecca Bachau. I actually said to her, I said, I actually kind of feel bad, not kind of, I actually feel bad for those who have never experienced what you just explained and what I got to experience every day. And like you said, these aren't 1 in 100s. These aren't outliers. This was every day in a practice where your practice is known for and you do early interceptive treatment to help these patients grow and are airway aware and make the appropriate referrals working with your medical colleagues. I can't tell you how many times I had the letters you just described, parents in tears, just tears of joy and exultation, just saying, think like how did everybody miss this? Dr. Mike, why were you the first one? Why are you the only one that ever looked at this? And my answer would always be, well, unfortunately, this just isn't the norm yet, but I'm going to try all I can to make it the norm. So that to me is really sad because I mean, our days can be tough, right? Running in private practice, what you do day in and day out, there's stress, there's challenges, there's headache, and you need those wins to keep you motivated and energized at what we do. And straightening teeth is great, great, right? Making people look great. I'm not minimizing that, but there is a level of connection and it just literally lifts you up, a level of elation when you or one of the kids comes over and just hugs you, right? When they're done with treatment. And there's a psychosocial side to this. I never imagined I would have the psychosocial impact on these young kids that I did. I wasn't obviously my point in starting to do this. I was trying to help the face grow. But when you make the face grow and you get the teeth straighter, I would see these 7, 8, 9-year-old kids, and the parents would say to me, they're a different kid. They breathe better, they sleep better, they do better in school. But they also came to me and said, they're no longer getting bullied. And I didn't even know they were getting bullied. And you take these kids who didn't want to go to school because they weren't performing well, they were getting teased for multiple reasons at school because of the way they looked or their attitude or all the above. And all of a sudden, they're these thriving younger kids and just they walk in, they're confident. I mean, again, I feel bad for the people in our profession who have never experienced that. I really do.
On that point of being teased at school and facial, because like you had young kids, so have I.
Mm-hmm.
Kids tease mercilessly at that 7, 8 year group,
Yes.
right?
Oh, yeah.
And I remember I got a second opinion a couple of years ago. It was a young girl. She was like nearly 10, okay, and massive overjet, like 12, 13 millimeter overjet,
Mm.
like no mandible, basically. And the reason for second opinion is the previous orthodontist had said, look, watch and wait, your kid's way too young, blah, blah, blah. But the parents had heard about me through a friend. And when I started talking to the kid and saying, yeah, we can do something now while you're young, we can help your jaw to grow forward. You could see like a little tear coming out of the corner of her eye. And I thought, oh my God, this is like really weird. And then the parents disclosed to me what that kid was doing, not to be teased at school. She was getting on the school bus, but getting off the bus a stop before school and spending the whole day in a stormwater drain just so she wouldn't have to go to
Oh,
school. And the parents only found out because the teachers rang her and said, look, where is your kid? They'd
oh
missed
my
like weeks and
goodness.
weeks of school. And when the parents told me that, I just felt so, what are you waiting for? I mean, and clearly the kid's got an airway problem. Like, come on, like, when you see those
Mm.
really horrific class
Mm-hmm.
twos, right? And
Mm-hmm.
I trained in the UK, and let me tell you, like every second person is class two, and we're talking severe class twos. Like I always look at the Simpsons episodes.
Oh
Like
yeah.
that could
Yeah.
be
Yep.
half of the English population.
Yep.
And again, it's like, okay, so max fac surgeons, what do they do when you're an adult with sleep apnea and your jaws are retrognathic? They do a massive
Right.
surgery
A big
called an
MMA. Yep.
MMA.
Yep.
And in the research, talk about research, the evidence is way up there that if you do a two jaw advancement surgery, with a genioplasty, you're going to improve a person's airway. You're going to take them off a CPAP. We all know that.
Yep.
But if we can do it at that age, what's to stop us avoiding the surgery and doing the same treatment, widening the jaws, bringing them forward, opening up the airway? Listen,
Right.
a good-looking face is a good airway. I think that if you're going to do another podcast or write a book, I mean, wouldn't that be the one? A good-looking
I
face,
love
good
it.
airway.
Yeah, it's
When, when
true.
when do you want to fix a bad airway? Like if a kid has poor eyesight and needs glasses, does a parent say, look, what's the best age appropriate for me to start giving them glasses?
Right. Right.
Hello, like now,
Right.
right?
Right.
So yeah, I'm as frustrated as you. Why our profession, and it's mainly the academics. I'm going to go back to that.
Yes, yes, I
I know
agree.
I know you're personal best friends with Kevin O'Brien, right?
Yeah.
So,
Yeah, yeah. He
and
reaches
there's
out to me all the
people who
time.
read his blog and just accept it on blind faith,
Yeah. I
right?
know.
Okay.
I know. That's why
Um,
I spoke up
uh,
on the way I did, because of that. Not because I have a
yeah,
personal gripe or want,
yeah,
it's not a personal vendetta. Everyone can believe and think what
not
they
at all.
want. It's
Yeah,
because people trust that and believe that, and it's
yeah,
it's misrepresenting the data and the research to advance their own agenda. And that's when I stepped up to
yes,
say, let's debate this. And for the record,
yeah,
I did offer to have a public debate with him. Brian Anderson had offered to moderate it, and he won't take me up on the offer. And I wanted to have it
yeah,
on the issue of sleep disordered breathing and interceptive orthodontic treatment. And Kevin, if you're listening, that offer will continue to stand. Or truthfully, anyone, if anyone wants to come on or debate me on that, have that discussion. And this isn't a personal thing for me in terms of trying to prove I'm right or you're wrong. We just need to lay all the facts out there. And Dave Singh, who was just on the podcast recently, said, and I told him I was going to steal this, but he said, in what you said of a good looking face is typically a good airway. He
yeah,
said the cranial base sets the pace for the rest of the face. And I said, I'm stealing it, because I'm going to borrow that from you, give you credit, but because it's true, the way our face grows, if it's growing the right way,
yeah,
then you typically don't have the same airway issues, right? If you have more forwardly positioned jaws, if you have don't have a transverse deficiency, you have wider arches. If you're growing more normally, you're going to breathe more normally. And I don't,
yeah,
again, you look at the medical literature, this isn't debatable stuff. And we've known going back to early 1900s, I use the quote all the time from Engel. I mean, you go back to 1907 and he said, of all the various causes of malocclusion, mouth breathing is the most potent. Like, this isn't a
yeah,
mystery. And
yeah,
even getting into the studies of getting into like this 1970s with Ricketts and the talking, his virtual treatment objectives and understanding with and people think of Ricketts, they think bioprogressive, but he also did a lot when it comes to airway and breathing and the
absolutely.
etiology of malocclusion. So it's been there all along. And the Harvold studies on the monkeys and the rhesus monkeys and blocking the airway. We know this. We also know it's not debatable. It's scientific fact that we are supposed to be nasal breathers. Our noses filter the air, they humidify the air. Our sinuses have nitric oxide that purifies the air, and it helps as a potent vasodilator make the oxygen exchange in the lungs more efficient. So we know we're supposed to breathe through our noses from a biological standpoint. We know that if we breathe through our mouths, that our face doesn't grow the right way. And we also know that as orthodontists, we can go in when patients are younger and very easily and efficiently redirect that growth. And we have the knowledge and the capability to detect these issues that are outside of our scope, tonsils, adenoids, nasal passageway obstruction through like turbinate hypertrophy, and make the referral to our colleagues. Because again, the literature is very clear that with allergic rhinitis and turbinate hypertrophy, they're profound problems in society today. So in the pediatric population. So I really again, that's where I just love to talk to someone like Kevin and say, oh, what are we saying in any of that? Can you really take issue with, right? Hey, everybody, be sure to check out the Doc website where you can get access to tons of great information, including free educational content, access to private one-on-one coaching with me, ADA CERP recognized CE courses, and amazing patient testimonials. Just go to theorthocoach.com. That's theorthocoach.com. And now back to today's episode.
Now, just on the point of angle, let me tell you how the world went upside down in our profession, right?
Mm-hmm.
So Edward Angle was one of the first orthodontists to not take teeth out. He developed all these systems
Completely. Yeah.
and he had this skull in his operatory, which was actually an Aboriginal skull, right?
Yep. Yep.
And they called it Old Glory.
Yep.
And
Glory,
it had perfect occlusion, no crowding, and he wanted everyone to do that. The problem was he was using heavy forces.
Yeah.
He was treating at the inappropriate age, and his two number one students, Raymond Begg from Australia,
mm-hmm.
Charlie Tweed, I think, Tucson, Arizona, they both waited until they graduated. That was quite clever. And then they started bad-mouthing their teachers, saying, listen, all his cases relapse. So rather than realize or research why they relapse, they came to their own conclusions that taking teeth out would be a good thing, right? Now, Beg did oh my God, he's revered as a hero in this country, and I take my hat off. Some of the stuff he came up with, the pin tube system, and is amazing biomechanical tooth movement stuff. But this was his thesis. He looked at Aboriginal skulls in South Australia, and he realized they had no crowding, right? And guess what he put it down to? He said, well, that's because their diet is goanna and sand, and their mastication forces causes interproximal wear. And that's why, but modern man doesn't have that diet, so we should take teeth out. Are you crazy? a guy called Corricini came to Australia
with the studies on pigs.
Yeah,
Corricini's pig studies.
And then he looked at Aboriginal skulls to match Begg's group, but on the eastern seaboard, where the Aboriginals were eating seafood, no abrasive diet. And guess what? Those Aboriginals also had beautiful jaws, class 1 crowding, and he put it down to their airway. So, so how can someone base their hypothesis of taking teeth out on that? And you and I know, I mean, I've taken a lot of teeth out in my career, which I regret. But those cases are no more stable than the cases that I've expanded earlier. Do you know what I mean?
So completely. And how many adults have you seen come in for retreatment that had 4 buys out and are still end on class 2, 100% deep impinging overbite, incisor relapse and attrition like crazy across the anterior teeth, right? I mean, we see that all the time. And arches that are about half the width that they should be. Oh, and the patient oftentimes is also struggling with obstructive sleep apnea as well. And again, people will say, oh, Mike, you're saying extracting teeth causes obstructive sleep apnea. No, I'm not. I'm saying that when you extract teeth because the etiology is a deficient width and or AP of the jaws, and you extract teeth to compensate for that, you're not treating the etiology. So you're not causing the sleep issue, but you're missing the opportunity to improve the sleep issue. And that's a big point that I make to people is, this whole like, oh yeah, extractions don't cause airway problems. Well, I don't really know many people who say they do, but not treating the etiology does. So,
and like, for instance, what's common in Australia for someone who has snoring sleep apnea as an adult, we just make them a mandibular advancement splint, right?
Sure. Yeah,
why?
US too.
Keeps the tongue out of the palate. Well, don't tell me that if you retract a lot when they're young, you're going to give the tongue more space. You're not. You're going to give the tongue less space. It's all about the tongue. And I mean, I've read a lot of research as part of my sleep medicine training. Sculpting of the tongue has a high correlation to the AHI, to the apnea. And why is the tongue scalloped? Not because the tongue's too big. It's because there's no room for the tongue in that palate. And, you've been excited, as I have, when you see these kids and you just develop their jaw and you're working with growth. And then all of a sudden, the parents tell you, hey, my kid doesn't wet the bed anymore. Hey, my kid sleeps really well. I used to put him to sleep and he'd toss and turn and he'd always be unrefreshed. He had that hyperactive behavior. And on that point, I mean, again, if you're only dealing with the adult side of this problem, you're going to see people lethargic and stuff like that. People don't realize kids behave differently to sleep disordered breathing. You've got young kids. If they stay up 1 hour past their bedtime, they're not tired. They are climbing the wall, right? And so a lot of these kids that have, and I'll remind me when we finish, I'll send you a little video I did just last week, right, of this little 5-year-old who is diagnosed with ADHD, right? And the diagnosis was made by the primary care physician without any sleep study, without any barometric testing, just because he could see the kid was just, hyperactive, right? And the parent brought him to me again. I've had a look. This kid has the narrowest jaws. Like, when the primary dentition is already crowded, kid's got no hope in health, right? But no one's talked about this to the parent, and they've automatically, with one consultation, been put on Ritalin. Okay, and I'm just saying, hey, I know there's a true ADHD if it's diagnosed correctly, but a lot of ADHD is the signs and symptoms are so close to sleep disordered breathing in children. So
and that's
close,
been proven in the medical literature. That's not even debatable. Like they have the medical, the otolaryngological literature, sleep. I mean, so many of these very renowned and prestigious medical journals have proven time and time again that the symptoms of sleep disordered breathing or sleep deprivation or obstructive sleep apnea in the pediatric population mimic the symptoms of ADHD. And like you said, we're not saying ADHD doesn't exist, or like people like to say, oh, again, this is one of the things that frustrates me with people who try to kind of conflate the issues here and say, oh yeah, see those people who say that expansion or young early treatment eliminates the issue of sleep disordered breathing or obstructive sleep apnea or ADHD. No, we're not saying that. We're not sitting here saying that every patient with ADHD should have early treatment to expand their arches or not even close. I've never, people who think like you and I think, I've never met one who ever took that stance. We all say, if their arches are broad and they have good facial development and there's not a lot of dental crowding and they're growing well from a craniofacial standpoint, and we don't see any obstruction from an airway standpoint to refer to our medical colleagues, and they can still have ADHD and nothing I'm going to do about it is going to help that patient.
Yeah, absolutely.
Conversely, if that kid comes in and they have the signs and symptoms of ADHD, but they have narrow arches, deficient arch width, maybe some mandibular retrognathia as well, moderate incisors or crowding, obstruction of the nasal passageways and or pharyngeal airway, that's a totally different story. And that kiddo, we can do tremendous things to help. We can go in and refer to our medical colleagues to help with the area outside of our scope. And then we go in and we help these patients grow. I mean, the ADA said in their 2017 position statement that we're supposed to recognize these issues, work with our medical colleagues, and then perform evidence-based treatment to address any structural issues. It's not more complicated than that. Like if you see a patient with a transverse deficiency, it is well within the scope of our practice to address it. And that doesn't mean we're saying that we're solving sleep apnea because of it.
Yeah. Yeah. And, Ricketts, with he traced more Cephs than anyone else in the world. But he was the first guy to say, listen, we're just looking at the lateral Ceph. What about the frontal? What about the transverse, right? And I remember I did a lot of his courses back in the day. And I remember him distinctly saying, don't be fooled that a transverse problem is only manifested by a crossbite. And he made the point, if you have a lower arch where all the teeth are like that, but there's no crossbite, you upright that lower to what it should be, and then you'll see the crossbite right in front of you. That was like a profound moment for me, who came from an orthodontic program where you only expanded if you had a functional shift of the mandible based on a true crossbite. That's what I was told. I expand a lot, right? And I don't look. People think, we do have some people in our profession who I will say expand for fun and profit. Do you know what I mean? Like every kid
unfortunately,
that comes in,
and they give all of us a bad name.
Their diagnosis is, yep, kid's got a pulse, let's get that expander in, right?
Yep.
And unfortunately, they give maybe people like us bad rep because it gives the academics a bit of fuel for their fire, saying, well, look at this, right? Yeah. But Ricketts was really on the ball. He had such an academic mind, right?
Brilliant guy.
And he was the first orthodontist, as far as I could see, when I looked at the literature, who was actually researching airway in mixed dentition, right? He was big on Rocky Mountain Orthodontics, for instance, for years had been the company associated with phase one in intervention. But but Ricketts' understanding of the transverse dimension and the room for the tongue was outstanding. So I just don't know why the profession has lost his way. I remember listening to a landmark lecture by Tom Graeber, right, when he first became the editor of the American Journal of Orthodontics. And what did he say? I'm going to change the name of this journal to the American Journal of Orthodontics and Dental-Facial Orthopedics.
Right.
Why? Because he'd spent a lot of time in Europe. He'd seen what the functional orthodontists were doing, and he said, we should be doing this. And then now what's happened? It seems to be cyclic, isn't it? We've gone from this, wow, yes, let's get in early, let's develop the arches, we know it works, to now the debate of like, should we be treating early? And is there any evidence to support that from an airway point of view? I don't understand.
No, you and me both. A couple things on that. One, your point with Ricketts and what a visionary he was, how much he saw it. I mean, if you look back, 20, 30 years predating him, when Broadbent and kind of the Bolton Broadbent cephalometer, when you're talking about it was two static images, one anterior posterior, one lateral, and they were taken with a patient sitting in one chair. And then there were mathematic algorithms that allowed you to convert those into 3D measurements. And it was, people don't realize this, it was actually a lot of the people who oppose 3D imaging today and stand by the power of 2D and how that's the way it should be done may not realize that the reason they got away from that 3D image, which they were trying to see, because from anthropology, they weren't studying 2D skulls in anthropology. They were studying 3D skulls. So they were trying to represent that and create landmarks and standard units of measurement to judge at that point, to really just kind of judge growth and the results of their treatment more than a diagnostic standpoint. And what they did was, because of market forces and space in offices, it wasn't practical for people to buy two machines and have to take two images. So what did they do? They condensed it to one machine. For, again, market forces drove this. And with that, they realized, oh, we'll just take a lateral. And then if we want an anterior posterior, we're just going to spin the patient, right? But you lost the ability to generate 3D measurements from those because the patient moved or the machine moved, or both. So people who are against, again, Ricketts saw it, but a lot of people who cling to the 2D and there's no need for 3D. Look, this started as 3D. The other point you make that I love in that is, I think what happened was, and people such as Gianelli, brilliant guy, Orthodontic, there's some people out there who were in the 90s and early 2000s. There's like late, maybe even the late 80s. They wrote a lot of literature. They were kind of loud voices in the arena, and they wrote a lot about how there is absolutely no place for interceptive treatment in orthodontic practice. And I think it really it kind of painted it with a bit of a stigma that was like, you shouldn't be doing this. Tunke said you're a quack if you believe in the value of interceptive treatment in a paper published in the AJODO. I think it was like 92, 93. Don't hold me the exact year, but early 90s. And so when you start seeing this, that has an impact on the profession. And then people coming out, like you said, academia, they're not seeing these younger kids. They're not getting the younger kids. So they don't get the opportunity to look into it. And so unless you go out in private practice and understand this a little more, or try it, or are willing to basically reach outside your comfort zone, a lot of people just don't do it. And I think the cycle is going to switch back, and that pendulum is going to shift with what we're doing, with what you're doing, what you said with like Audrey and all these people that are doing and putting this data out there to say, no, we need to teach this. We need to educate our residents and our younger doctors that this is a thing and it's real and it's not some fringe thing. And it's not about just, can we fit the teeth in, which is, I think, what phase one got relegated to in the 90s and early 2000s. It was this like non-extraction extraction debate. And it became this whole thing of the extraction camp and non-extraction camp. And you stop and say, time out. Can we just stop making this about the teeth for a minute? We're so much better than that. And we have so much more knowledge than that. And on that note, I would love to have you explain to me a little bit about your diagnostic process. So take me through, just for people out there that hear this and may not do this or may do it and wonder if they're doing it in the best way. How, when you see that, you said like 6, 7, 8, 9-year-old come in, they present to you, what's your overall diagnostic process? And then if you do detect in that process that there may be there's signs and symptoms of sleep disordered breathing, how do you proceed at that point? Have you heard about the Doc Community on Facebook? It's where you can get access to more great content, including case reviews, select clips from CE courses and podcasts, literature reviews, and exclusive promotions and discounts off Doc educational materials. Just go to Facebook and search for the Doc Community and submit a request to join the group. And now back to the podcast.
Yeah, thanks. It's a great question, because I think that's what every orthodontist is looking for. Like, okay, we understand what you're talking about. On Monday morning, how do we try and integrate this into our practice?
Right, yeah.
I've been following the research for many years from a guy, his name's Dr. Zarush Zaghi. He is a super qualified, ear, nose, and throat sleep surgeon.
Okay.
And I was introduced to him at Stanford through Christian Gumino. And he has this protocol he's put together for dentists, right? He calls it the 6 flags. And it's something that I use every day in my practice. It starts with, okay, so like when you became a resident, and we all taught how to do records. What are records? Study casts, which are now, digital, X-rays, which as you said, well, unfortunately, lateral cephalin just a pano. But now for my practice, I mean, I got my first CBCT in 2010. We
Wow.
now have 8 clinics, 8 CBCTs.
Wow.
I love that. And we set settings so that one of our exposures is less than one panograph
Same.
as far as,
Same. Oh, we're
right?
so similar.
So why
Yep, you got
wouldn't
it.
you do that, right?
Yep.
The
And
only
it's
thing
plenty
is,
to see. You can make as much, and unless it's like a cleft craniofacial case, need more detail. That is plenty of diagnostic data to determine what we need to determine.
exactly. And the other thing is, there's a guy called James Metz from the US, right, who developed a good protocol on head posture and where the tongue should be when you take that CBCT, so it becomes reproducible. I know Mariana Evans. I don't know if you've heard of her.
Sure,
She's she's taken a CBCT of herself 3 times, 5 minutes apart, and the airway volume changed every X-ray, right? So a lot of people who knock CBCT say, it's not diagnosed. We're not saying it's the only thing we rely on, but my God, it's so much better than a 2-dimensional X-ray, right?
Right. Just because it's not the end all be all doesn't mean that it's not a huge improvement over 2D.
Exactly. So for me, what's changed the way I currently diagnose compared to what I used to do? First of all, we've gone for 3D imaging, right? That's a biggie.
Okay.
Using Metz protocol to make sure, and basically just the kid expires there until they can hardly breathe. Then we take the X-ray. That
interesting.
Gives us the root, right? And they look at their own eyes in the mirror, so we get the Frankfurt horizontal. Okay. Second thing is, every kid before I see them is given a pediatric sleep questionnaire, which the parents fill out. That's such a biggie. It costs you nothing. You throw it out there, but you'd be amazed at the responses you get, right?
Yes, you would.
Right? Yeah. And in Zagi's protocol, then we measure things that I never measured before. If you ask average orthodontist, are you measuring tonsil size, right? Are you doing a Mallampati score?
Sure.
Are you looking at all the things we see? Bruxism, narrow arches, is the kid a mouth breather? Then there's so many free apps now that I give to parents, because if I ask a parent, does your child snore? Which is a huge, important question. Most of them are going to tell me, I don't know, the kid hasn't slept next to me for years. They 3 bedrooms down there. I don't hear them. I said, listen, download this free app. It's called Snore Lab. It's highly accurate, doesn't cost you anything. So with a pediatric sleep questionnaire and something like a Snore Lab app, I get data, right? And not every kid is going to need my intervention, as you quite correctly said. But
and I'm
those
going to put both of those in the
show
notes, by the way, the PSQ and that link to the app as well. I'll put both those in.
So if they come back with high scores for those 2, I'm going to look a little bit closer, right? Then I'm going to do some measurements. And what's his name? Conrad Maurice did this fantastic research at Harvard, where he looked at, I think it was part of Bolton's study group as well, but he looked at dental arches to see which kids needed orthodontics because of crowding, which kids had nice arches and no crowding, right? But one thing that people didn't really get from his study, he said that the intermolar distance, right, between the first molars by age 7 doesn't change. That's huge, right? He also said that, if your intermolar distance is about 37, 38 on his study, that's kind of a nice arch form. You know how many kids I see who have an intermolar distance like of 25 and 26? So I think, again, and Zagi makes a point of this in his, I'll send you the link. Maybe you want to put that up, his 6 flags of measuring the intermolar distance. Now, let me tell you, every orthodontic dental company in the world who makes a cotton roll, the cotton roll is 38 millimeters. That's a fun fact, right? So if you just shove a cotton roll between the molars on a young kid and there's no way it even fits, Houston, we probably have a problem. But I'm not using that as the only guide, right? So everyone says, right, so my CBCT, my intermolar distance, my pediatric sleep questionnaire.
And what on CBCT specifically, if you could, what are the main things you're looking for when you're looking at the CBCT?
In the CBCT, we're looking at nasal obstruction, right? It's the best X-ray to look at large turbinates, large adenoids and tonsils. We have a software called Anatomage. You've probably heard of it.
Absolutely.
It maps out for me really quickly upper and lower airway volume. And again, it's just a comparative to norm. And it just allows me to see that velopharynx area,
Yep.
the area
Of
of the
course.
airway behind the palate,
Yep.
you can see that that's so narrow. I remember one of McNamara's papers where he talked about his bonded Hyrax face mask protocol for
Hmm.
class 3, right?
Hmm.
What he measured was that distance. And
Hmm.
what he showed in class 3 patients, it hugely improves. Well, guess what? He wasn't talking about it, but what you're improving is the airway. I
Hmm.
mean, it's a
Right.
no-brainer. But
Right.
if you ask the average orthodontist, can you tell me what the airway volume is for your kid? They're not going to know, but there's
No.
so much research to show you that minimum cross-surface area from a CBD done properly is a great guide. And
Yep.
again, just a guide,
Got it.
right?
Yep. Yep.
So these are the things that I look at. And you're right, not every patient then who's 7 in my practice leaves with a phase 1 treatment plan. If they have nice arch forms, they're sleeping well,
Hmm.
canines not ectopic, all the stuff we
Yep.
learn. I'm
Yep.
not going to do anything.
Right.
But let me tell you, the number of kids that come in to me who are mouth breathers, who snore, who have
Yep.
narrow palates,
Yep.
it's more than the norm. Would you agree? I mean,
Completely
there's all
agree.
these people saying what percentage of people who have malocclusions have OSA. That was one paper I remember
Yeah.
Audrey Yoon was discussing, but they only based it on one thing, which was the pediatric questionnaire.
Mm.
I've started research, which let me tell you, I'm a clinician. I go to work and I work like 10 hours a day. So, um, uh, and I and I've got all this data because of the number of patients I see. We're a huge practice, right?
Yeah.
And
Isn't your
I've
PhD?
collected
Am I wrong that it's over 3,000 patients in your
exactly. So we have
That's amazing.
3,000,
I saw that
yeah,
number. I was like, oh
3,000
my
sort of
God.
866, right?
Oh,
Patients who have this protocol that I've collected the data.
amazing.
And I've asked Audrey because she's also a great clinician, but she's got an academic thing. I'm not an academic, so I'm working with 2 university groups who are helping me analyze this data. But what
Hmm.
we're seeing when we measured sleep disorder breathing, and remember, I was the only orthodontist, I'm pretty sure, in the literature that has asked for a full overnight PSG for all these patients, right? I was able to do it because my sleep physician that I work with, who believes in what I believe in, was happy to do the sleep study without charging the parent. So
Wow, amazing.
you're not doing anything invasive, right?
Right.
So you're not. Right? So I have this protocol where they've all had X-rays, they've all had models, but they've had 2 things that no one else has had: a full sleep study and a Bayes questionnaire. And then I'm correlating how many of those had what type of malocclusions. And what am I seeing so far? The class 2s with the retrognathic mandible
Hmm.
and the class 3s with the retrognathic maxilla. Both of those score high on the airway problem list. Common sense, right?
Yep.
But guess which are the most highly rated worst figures in their sleep? The people that were biskeletal retrusive, what
Hmm.
Kevin Boyd calls class 4, which he says we should
Mm.
have a new classification, right?
Yep. Yep.
What is class 4? Biskeletal retrusion,
Yep.
long face. They've got every airway narrowing known to mankind,
Yep.
right? Now, some of them get away without having any problems in the sleep study
Hmm.
because they have airways that don't collapse,
Hmm.
right? Did you
Hmm.
you know that it's not
Hmm.
all about the size of those what's the soft tissue
Collapsibility.
doing,
Sure. Yep.
but but again, as a guide, they're the ones that I'm finding definitely need the help, and they're the ones that
Hmm.
we can help because
Yes.
what other profession in the world knows how to widen a maxilla and bring it forward, or upright teeth in the mandible,
Right.
bring it forward? No one else. We're the gatekeepers of the airway.
Right,
Man, yeah.
right. And so many of our colleagues will say that you can't eat, like, I mean, that, again, we're not talking about expanding a mandible. Let's be clear. It's extraction osteogenesis for that, but expanding a mandibular arch, dental alveolar tipping and remodeling and uprighting of the teeth. And so we're having this conversation, and there are a lot of people listening and be like, that literally not only is the airway side, a bridge too far, but just they're like, wait, what? You're expanding the lower arch? I mean, but yet, if again you go back into the 60s, Schwartz and Gratzinger, the Schwartz appliance, McNamara has studied that appliance, the Arnold expander. We've had so many examples of expanding the mandibular arch, and it's stable. And yet again, people literally, it's like blasphemy when you say that you're going to go, and you, like you just said so well, we know how to upright teeth. We know how to, if the mandibular bone is wide and the teeth are caved in, that's, even if, take an ABO score, curve of Wilson is something you get scored on. So like, we need to fix that. We can fix
Yeah.
that. Why is it so out of control to talk about doing that? on a young patient. So that's one. And then two, kind of let that transition into letting, if you could just kind of explain, how do you approach it when you detect one of those patients you were describing? How do you deal with if you see something that requires referral, what your typical protocol is for that, and then what your typical clinical protocols are for treating those patients?
Yeah, so I guess I can go through my clinical protocols and also what I had to put together for my research protocols.
Yeah.
And again, David Gazal helped me a lot with that. So from a research point of view, every one of those kids I sent to an ear, nose, and throat doctor first, right?
Okay.
Just to do a nasal endoscope and confirm or deny was there any dramas. And the ear, nose, and throat team that I work with, who follow the Zagi protocol, also look for tongue tie. That's a big one that, again, that I never used. I had no idea what a tongue tie was, let alone a posterior tongue tie. Okay. So anyway, so the ear, nose, and throat looks for the tongue tie, looks for the airway. That's number one. And sometimes those kids just get T's and A's, and their sleep improves straight away. What you don't realize in the literature, though, is if you're looking at, say, sleep disordered breathing or apnea scores, T's and A's will give you an improvement, but not total resolution. There's still residual AHI. Now what? Right. Well, that's when I came in with my protocol, which is those kids who need it, maxillary development. Now, when I say development, everyone talks about expansion, but it's the AP position of the maxilla that's so important, right? So a lot of my kids and my protocol in these airway compromised children, I developed the arch. We use an alt-ramic protocol, which is very well researched by Frankie Bacchetti, University of Florence, when they did that. And we use the McNamara's protraction. The only thing is I don't use a chin cup on my headgear. I use a face mask developed by Dwayne Grumman's, another fantastic orthodontist, right? Okay. So the Grumman's mask with semi-rapid expansion is what I do in the maxilla. And then I kind of believe what McNamara talks about, that if you get the maxilla in the right position early, the mandible just follows, right? Because the patient kind of has to chew and masticate.
The foot in the shoe of McNamara.
Exactly. However, because I expand so much, right? I expand now to crossbite, like a scissor bite, if that's the term you guys use. Brody bite, I'm not sure what the correct term in America is. Yeah, okay. But then I have to upright my lower molars, right? And that's so easy to do. I do that with 2x4 mechanics, like classic Rickett stuff. So in the maxilla, I set it up to the right dimension and right position. Then I see where the mandible is, but I upright those mandibular teeth from the majority of my patients, making lots of room for the tongue. If need be, I use a device called a Mara. It's a mandibular anterior, and that allows me to bring my mandible forward without encroaching my tongue space. I used to use twin blocks, and God bless Bill Clark, one of the first orthodontists in where I graduated, to talk about airway and talk about orthopedics, right? But the problem with the twin block, I find, number one, compliance. Are the kids going to wear it? Number two, that they can't talk with it. And I'm trying to encourage the tongue to sit on the palate. You can't with all that acrylic there, right?
Agreed.
So the appliances, the orthopedic appliances I use are appliances that allow my tongue to sit up where it should while I develop the arches. So basically, I get the maxilla size and position, mandibular size and position into balance. Now, what is a balance? Like, forget about using standard septometric classifications. I grew up with Steiner, right? That is a dental thing. We're talking orthopedic. So we use like the Bimbler Sassoon modification. It's called an anterior arc. So I get my maxillomandible to that arc, which is a skeletal one. And as Dave Singh will tell you, based on that patient's cranial base, not based on anyone's norms, right? And once I do that, the face looks good, the parents are happy, there's so much room for the tongue, the breathing improves. And guess what? The icing on the cake, the bonus is there's room for the permanent teeth. That's just the bonus.
Yes, I so agree
with that.
That's
not the focus.
I so agree with that.
That's not the focus.
That's the bonus. That
and I tell
and
parents,
the way they look.
Exactly. And I tell parents, I'm not doing this for the teeth. I know you think you've come here for an orthodontist and you're trying to avoid extraction of teeth. Yes, we probably will, but I'm doing this because your kid has an anatomical narrowness of their jaws, and I'm just fixing that to big difference. My practice philosophy is airway first, teeth last. Right. Big difference.
I love it. And the nice part about
one thing I forgot to mention, which is so important. how do I retain that? Because
I
that's the
was, I
big
was,
thing,
that
isn't
was
it? Right?
literally what I
Yeah.
was just going to ask you. That's, yep, yep,
So, because we're talking a kid who's maybe 7 or 8. By the time
yep,
I finish what I'm doing, they're maybe 9, 10, right?
yep.
So, what I believe the tongue, if it sits on the palate, is your best retainer.
Agreed.
So,
Yep.
so most of the retention I do is based on myofunctional therapy. And again,
Mhm,
Christian Gumner put me onto this. He
mhm,
said, listen, you guys can fix the problem anatomically, but you're not rehabilitating the airway. That was his famous quote,
mhm,
rehabilitate the
mhm,
airway. And he gave me a paper once which blew my mind. He said, "You are from Australia. Do you know that if you play a didgeridoo, you don't have sleep apnea?
mhm,
You can improve your sleep apnea by." And I said, "Wow, really?" And here it is, British Medical Journal saying that. Why? Because the muscles of the
mhm.
pharynx, when you play that, are constantly exercised.
Yep.
So again, myofunctional therapy is a big part of my phase 1 retention. And if
Mhm,
they do those exercises, right? And you know how many times in my practice I hear my TC saying to that kid between phase 1 and 2, lips together, breathe through your nose, tongue on the palate, right?
mhm.
We
Yep.
we hone that in. We hone
Yep.
that in.
Yep.
And the kids who do that, let me tell you, without any doubt, they don't need a full round of fixed orthodontics
Mm.
at
Yeah.
all. Do
Yeah.
you know what I mean?
Yeah.
Yeah.
I had so my,
So yeah,
my, the thing about our specialty I love so much and where I think we need to focus more on is we can debate and discuss and learn from one another on different techniques, right? And that's the fun part
yeah,
about it because that's how we get more efficient and get better and try different things and experiment and say, this worked better for me. I get that. I get we're not all going to do this the same way. What I don't get is why we don't all agree on the fundamentals and the science of what we're trying to achieve. But again,
absolutely,
we've spent a while
absolutely.
talking about that. But it's so funny because I have a different approach to getting there. But I find the
Yeah,
exact same thing in the end. And I love it was so great. People say all the time, like, oh, and one of the things that drives me nuts is when you hear people say, I mean, it absolutely just makes my head want to explode when I hear somebody say, don't get the teeth too straight in phase 1 because then they won't need phase 2. And I'm just like, how can you even, and that comes from a lot of people who are like anti phase
yeah,
1. You shouldn't even be doing it. There's no
yeah,
need.
yeah,
And it's like how number I won't even go there because it's not worth but that is something that's said a lot, probably to the
yeah.
surprise of a lot of patients and parents who might be listening to this, but I'm going to call it like it is. And so those patients I loved when they didn't need a second phase, and the parents loved, the kid loved when they needed a second phase. And it was the discussion of they'd come in and I'd watch them in retention, and I'd wait till the second molars had all erupted and all the teeth were in, and I'd look and it looked good. Bite looks good. And I'd say to them, yeah, you got maybe a little rotation on a canine that came in, or, maybe you had a little premolar rotated. And I'd say, this is that, but your occlusion's great. You look great. How do you feel about your smile? I love my smile. Okay, great. Well, I don't see a need for you to have anything more. I'd make a set of retainers to wear nights only indefinitely. And I'd say, if those little things ever bother you, we certainly can do something about it, or at any point in your life, it can be. But when you do that, number one, how can you, not you, but how can the people who oppose this argue that you haven't done an amazing service for that patient, right?
Yeah,
And you talk about
absolutely.
stability. If you took that same case, right, and didn't, let's say this kid at this point is, I don't know, 13, 14. If you took that same case and started at late mixed dentition, early permanent dentition, kind of like Gianelli talked about, right? Focusing on just fitting the teeth in, maintaining e-space, trying to do all these things to fit the teeth, and then extracting teeth if you couldn't get the teeth in, there is no way that is going to self-retain and be as retentive as the patients we're talking about, because I've done it both ways and
Absolutely.
I've seen it
Yeah,
both ways. And
yeah,
and if they did need a second phase, it was, because some do, it was just such an easy process for everybody. It was quick, it was efficient. I had in Orthotown, I had a couple articles in there, and one of them I showed some of these cases. One who didn't need a second phase was in this past November of 2023 in Orthotown, and one who did need a second phase, and how quick and easy and efficient it was. And I think that's the key. If we can get people to understand, it's a mindset shift. Instead of leaving all the heavy lifting until they're an adolescent, let's do the heavy lifting when they're young and pliable and compliant, because kids at that age, mom and dad can still
yeah,
tell them what to do, and they're going
yeah.
to listen more than
Absolutely.
a teenager. And they're easy to treat, they're fun to treat. And then on top of that, you change their life from a psychosocial perspective, from a health medical perspective in a lot of these kids. You change the family's life. And I think that's why, I don't want to put words in your mouth, but from getting to know you and talking to you about this, I think that's why we share such a passion for this, because we've seen it, we do it every day, and we look at it and say, how could you think this isn't good? Right?
Yeah, absolutely. And talking about what's the best age to treat, as an orthodontist, I love treating 7 to 9. Those
Me too.
kids, they've
Love
got
it.
a sense of humor. Let me tell you, like, I don't know how old your kids are. I have 4 kids that are all grown up, but when they were teenagers, I kind of remember, I always thought, geez, now I understand why some animals eat their young,
Yeah.
right? Like
I have teenagers right now.
right? You
Yeah.
think, what the hell? And for every orthodontist out there, you know the attitude teenagers have. Why
Yep.
would you want to treat at 13, 14 and do your heavy lifting then?
Yeah, right.
When kids are 7 to 9, they are the nicest kids in
I
the world.
agree. It's so
And
easy.
yeah,
Once they
it's
trust
a
you, and once
no-brainer.
they trust
It's a
you,
no-brainer.
it's so much fun. I'm glad you said that, because I don't think I say that enough, just how much fun
Yeah,
it is treating kids at that age.
absolutely. And
It's
I
just,
learned something from one of your podcasts that I was just doing coincidentally a different way, but again, like there's different ways to get to Rome, all right?
right.
But I like your point. If we all agree, position of maxilla, size of maxilla is important for
Hmm.
airway, and
Hmm.
how we get there is up to
Hmm.
us, right? But I've had a lot of kids who have airway problems and also are very disruptive in the chair, all right? Like whether
Hmm.
they have some form of ADHD or
Hmm.
cerebral palsy or whatever.
Hmm.
So I just can't get my expanders in for those kids.
Hmm.
It's just hard work, right?
Hmm. Hmm.
So I have been using, and I'm trying to think of his name. He used to do a lot of lectures with the sort of Damon camp back in the day, and he showed a case of a cleft palate kid in primary dentition where
Hmm.
he used self-ligating brackets, and he got this amazing expansion,
Hmm.
right? And I remember listening to that lecture 10 years ago.
Wow.
Geez, I'll remember his name probably after the podcast. And I went up to him and said, "Oh my God, do you see that rig?" He goes, "I see it routinely now. If you use light forces, you don't even need an orthopedic implant." So what I did is I went back, and all those troubles from kids that I didn't start, because I said, look, when Johnny's a bit more mature, I'll try and get that expander in. I got them back in, and I started doing this very light, 014 copper
Yeah.
nitride,
Yeah.
and my God.
Yeah.
And then I compared some of my arches to those who had the expander, and I found that this part of the arch, if I
Yes.
didn't have the expander in there, probably dropped down more because there was
Yes.
nothing. You know what I mean?
Oh, that's why
So
yeah,
yeah.
without a doubt. That's why I
So
went in that
so so
direction.
so, so again, there's different ways to kill a cat, right? And as long as we all agree that developing the arch, dropping the palate, helping the airway, getting room for the tongue is an important criteria, then how we do it is really up to us. And if it works, it works, Yeah.
Exactly. And I built a CE course on my website
Uh-huh.
built towards the cleft craniofacial side, showing exactly that. And the surgeons love it, because one of the biggest challenges with cleft craniofacial is once you get the expansion, that's when the surgeons are like, well, now I need to go in to do my grafting or fistula closure, or
Yeah.
both in sequence. And maybe they need a tongue graft if the soft tissue defects are big enough. What's the biggest problem? You've got an expander in there, and the stability, obviously you typically don't have midline palatal bone, hence the cleft. You don't have a lot of stability. So you take it out, you try to give them like a holly or something, but then they can't wear it around the surgery, and you get this relapse. I would send them for surgery with the braces on. And the surgeons
Yeah.
loved it, because they didn't have to worry about the collapse, and they could do whatever they needed
Yeah.
to do. And so it really, actually have to give credit to Shuna Teo, who I'm going to have her on in the future. She's a brilliant pediatric cleft craniofacial surgeon, and Jason Mouzakis, who's a brilliant ENT up in upstate New York, where I was practicing. And they were some of the ones that really pushed me to go in this direction and teach this, because they said, and they were just like, this will change how people approach these cases and help this. And again, those are the little things that kind of prompted me along. But that's it. You just try different things, you see different things, but our goal should be the same, right? I mean, we should
Yeah.
have the same objectives, and just have some nice academic debates and discussions on the best ways to get there, and learn from one another, not be fighting over whether airway's a thing, and
Yeah.
whether
Yeah.
phase one can help, right? I mean, it just,
Yeah.
yeah, it's really it's really something. But no, I really appreciated this. I mean, honestly, Derek, you're just, you I don't know how you do all you do, and have the time to be doing this research, as well as being running 8 clinics, and having, I think you said you just opened another one recently too, when we had spoken before. And it's just amazing. And I thank you not only for being on the episode and the podcast and contributing your knowledge to share this, but just for what you're doing to be a voice in this arena, and beating that drum, because I really do believe, if people like yourself, if we can just keep getting that message out there, and just putting our cases out. And I've always said, look, that's why I put a lot of the free content out there, podcasts, just like, look, this is what I'm doing. And I will stand behind it all day, but it's really great that you're willing to not only be doing this, but to take the time and energy that it takes to do something like be on a podcast like this and try to get that message out. So thank you so much.
My pleasure. And I just remembered David Paquette. That's
David
that
Paquette,
orthodontist
sure, yeah,
who,
yeah.
yeah.
Oh, I didn't know Dave did that. Yeah, interesting. Okay.
Yeah, he showed
Cool.
me those cases on these cliff. But so there you go.
Yeah, no, Dave's
Well,
great
no, it's a
guy.
pleasure.
Yeah.
It's great. I mean, it's so good. Like what did Martin Luther have that saying? I have a dream. I have a dream that in future every orthodontic resident will have the passion that you and I have,
Yeah.
based on on airway. That would be my dream come true.
Yeah, my residents I teach at Nova, I said, you guys are either going to do this when you get out, you're going to be really sick of me and you're going to be talk about this, because I am so passionate about it in that way. But yeah, well, thank you so much for taking the time and sharing that. And thanks for the great links and information. We'll coordinate after this to get all those in the show notes, because that'll be really helpful for people to have some places to go for more on this.
Excellent.
Awesome. All right. Well, thanks so much. Really appreciate it, Derek.
Pleasure. See you.
Take care. Bye. Thank you for watching this episode of the Doc Podcast. Be sure to visit theorthocoach.com to get access to ADA CERP recognized CE courses or to schedule a private one-on-one coaching session with me. And remember to join the Doc community on Facebook for more great content designed to help you succeed both personally and professionally. Just go to Facebook, search for the Doc community, and request admission into the group. You can also find Doc on Instagram at @theorthocoach. And always remember, you have been blessed with the ability to do amazing things.